Okay, lot of questions. So I think some of the questions have been sent to individual faculty. There are more coming. We'll continue to answer. Maybe we can start with the first, our speaker, Dr. Greg Stone. Some questions have been directed to you. If you can read them, with who sent it, and just a brief bullet answers for all the questions, because there are a lot of questions today. Right?
Sure, I'll try to remember. I deleted the email that had the questions on it, but I think I remember. So one question, a basic question was, how can you have a substantial plaque burden if it's only a 30% angiographic stenosis? And that's a really important basic concept for people to understand. The angiogram only shows the lumen, okay? And we know that when you start developing atherosclerosis, what actually happens is that plaque gets deposited in the media and the artery grows outward. That's called the so-called Glagol phenomenon. So you can accumulate a lot of plaque in the vessel because the artery keeps getting bigger and bigger and bigger. And it's not until you get to about a 40% cross-sectional area narrowing where the plaque starts extruding into the lumen. And if you have diffuse disease in addition, then the whole lumen can appear equally narrowed. So you can't tell how much plaque there is. So the plaque burden refers to that cross-sectional narrowing, and you can have a huge amount of plaque in the artery and a substantial narrowing in a cross-section of an artery where the lumen on the angiogram appears to be only mildly diseased or even normal. Another question was what do you do with an asymptomatic person who had a calcium score of 1,000 and is being treated with a statin and has an LDL of 50 and is absolutely asymptomatic, has no ischemia on a treadmill, and exercises to 12.9 meds. And I think the answer is today, you're doing everything you can. You want to aggressively manage that patient's risk factors, but the patient is asymptomatic, has normal exercise function, his LDL is quite low. We don't yet have data to say you should add a PCSK9 inhibitor and drive him under 30. Some people do believe that. If he's not on a maximal dose of statin, you might increase the maximal statin to the maximal dose. But with an LDL of 50, I think you're doing pretty well. Make sure that all the other cardiovascular risk factors are strongly optimized. We don't yet have data to say you should do an invasive interrogation to look for vulnerable plaque and then potentially either treat it with a PCSK9 inhibitor or with a stent. But we'll be presenting some data toward that end in TCT in about 3 days with 2 new studies, one of which is randomized called Prospect Absorb about the prophylactic treatment of vulnerable plaque. And I can't remember the third question, so I think I'll stop with answering those first 2.
Yeah, so well, we'll come back to more questions. There are more coming. Now, Roxana.
Hi, I didn't get the questions either. So if you have them, Dr. Sharma, you can read them and I'm happy to answer them.
Okay, so now one question was, what criteria do you use to qualify patient with a low versus high bleeding risk? And is there any publication?
Yeah, I mean, I think that's it's a great question. And there are obviously multiple risk scores that are used for evaluating bleeding and ischemic risk. But I think the best possible way to define a patient at high bleeding risk is using the Academic Research Consortium ARC bleeding HBR definitions for defining an HBR patient. And that as long as you get one major of those criteria or 2 of the minor criteria, you get in. And those are listed in, elderly, CKD, prior stroke, malignancy, there's several, prior bleeding, all of those things are all listed as a very, very good reference that you can use. It's the best, I would believe it's the best possible way of really qualifying that, certainly in clinical trials, and that's what we're going forward with. But the other thing is that none of this takes away your clinical judgment of what you believe is a high bleeding risk. And sometimes that, to me, is even more important. A patient on an oral anticoagulant, an elderly, frail woman, for example, who's small in size and is at risk for fall. I mean, those are the kinds of things that are really intuitive senses of high bleeding risk. And certainly anyone who's had a prior bleed fits into that category.
Now, other question is that if you are giving with the NOAC clopidogrel, should you be testing it? You do need to worry about people who will be non-responder immediately after PCI?
I think that's a really good question. If you're going to drop aspirin really, really quickly, and you just did a left main PCI in a high bleeding risk patient and with atrial fibrillation on NOACs, and you want to send them home and stop the aspirin, you better check it. I believe that you should be checking that. And I think in a very high ischemic score, ischemic burden on the patients with multiple stenting, left main, et cetera, I would say in those patients, you probably want to definitely test them and give them about 30 days of aspirin on top of it. Now, the default therapy, as I said, is really dropping the aspirin. And this 2020 consensus document, which is in press at the moment, will let us know for how long. If you look across the trials, it's somewhere between 0 to 14 days from all of the trials when aspirin was dropped in the randomization arms of Pioneer and Trust, Augustus, and Redual. So we are giving up to about 7 days or so for those patients when you're going to drop the aspirin.
Yeah, so I think that's an important point. I think based on complexity, many of us in the cath lab, as Dr. Maran pointed out, give it for 1 month, 1 week or so, and many of the cases can be dropped, and I actually routinely drop it. But yes, we don't have a clear-cut guideline, but yes, the studies are up till 1 month. So key is that can you do less than 1 month will be the major issue all the time. So now actually come back to Greg again. That's a very important question, that patients with ACS, with acute STEMI, and which patient should you be testing for the lipid-rich vulnerable plaque based on the risk factors? And if you find a plaque into other vessel, which you already mentioned, what you do with terms of vulnerability in the non-ischemic vessel, non-culprit vessel. Culprit you already took care with the stent. Now you found, based on your prospect data, how do you guide it till the data which will come with a prospect 2?
Sure. Well, again, we'll be presenting the late-breaking trial in 3 days, so I hope everybody will be able to join us for the virtual TCT Connect. We'll have a lot of new, very insightful information about that question, where we did 900 patients with STEMI and non-STEMI, and that did 3-vessel interrogation with NIRS IVUS. And we also randomized a subset of those patients to either treatment with a scaffold versus medical therapy alone. So it will be, I think, very interesting in relation to this question. But what we know going into this trial is that in patients with either STEMI or non-STEMI, there will be about 4 or 5 additional substantial plaques that you don't see in the coronary tree, that usually have an average diameter stenosis of 20 to 30% on the angiogram, sometimes even less. But they'll be very bulky plaques by intravascular imaging, and they're often lipid-rich. And we know that about 1 out of 3 of those will be a thin cap fibroatheroma, the ones that place the patients at particular risk. So the real question is now, should we look for those? If we find them, how much extra is the risk? Right now, we can only find them through 3-vessel imaging. What we showed in Prospect 1 was using virtual histology. What we'll hope to be able to demonstrate with you in a few days is whether or not near-infrared spectroscopy is as good or better. And if you do find such vulnerable plaques, what should you do about them? Should you intensify your lipid-lowering therapy or anti-inflammatory therapy? Should you consider focal plaque passivation with stenting? And we'll be getting at those questions by showing you the results of the randomized prospect absorb data. So today, where we are is that we don't yet have an indication to do 3-vessel intravascular imaging. We know patients with STEMI are going to have a lot of other plaques that you can't see. They've got diffuse atherosclerosis, and they'll have a lot of vulnerable plaques. So my general recommendation is, even knowing that, even not demonstrating that, you certainly have to very powerfully control their risk factors and drive their LDLs very low. Currently, the recommendations are less than 70. I would drive them down to less than 50. And if it was me or a family member, I'd want to see them as close to 30 as possible. So I'd have a very low threshold for a PCSK9 inhibitor if a statin is not doing it, or statin and ezetimibe. And again, finally, what we're the potential to be able to transform the field to say we should be looking for these and consider plaque passivation, because we know these vulnerable plaques can have a 10 to 20% adverse event rate within 3 or 4 years. We should be able to do better with stenting. These are non-fold limiting lesions. There's no indication to treat them today, but we should be able to reduce that rate with stenting. But again, we'll show you the results of Prospect Absorb in a few days. That's a pilot trial. Then we'll need if that's sufficiently convincing, then we need a large-scale randomized trial to really show the safety and effectiveness of that approach.
So actually, towards that is another very important question, that do you recommend in a FFR negative patient with some chest pain, plaque burden more than 70, or lumen cross-sectional area of less than 4, would you stent this patient?
Well, today,
FFR is negative.
Like I said, today we can't recommend that. Today we can only really recommend for ischemia, considering stenting patients with a positive FFR or IFR. Demonstrated, we've got to also think about the wisdom of that and really reserve that for symptomatic patients. Now, that's in stable ischemic heart disease. What about in acute coronary syndromes? Well, we've learned from the complete trial that after a STEMI, any severe lesion that is either angiographically severe or positive FFR, then you want to, quote, prophylactically treat that, because you can reduce the myocardial infarction rate. But whether we should be doing that in less severe lesions and that are FFR negative, today the answer is no. We don't have data to do that, but we hope to be able to generate randomized trial data in the future to support that indication.
Okay, great. Now, I think Dr. Bill Abraham, you got your questions. A lot of interesting, some of them actually you answer by your presentation, but I think if you can just answer there, because there are many questions for you.
Yeah, absolutely. Let me go ahead and bring those back up. Okay. So some of these relate to CCM and ICD therapies. One is what about the combination of CCM and ICD therapies, and certainly that is an attractive combination. Currently CCM comes as a standalone device in patients who also have an indication for an ICD, either a primary or secondary indication for an ICD. They'll have to have 2 devices currently, a standalone ICD device and a standalone CCM device, but as mentioned, there is under development a combined ICD CCM device, and that will really be an additional breakthrough for our HFrEF population. I think one of the reasons why we see the penetration of primary prevention ICDs at being something less than desirable in the indicated population is that while primary prevention ICDs reduce the risk of mortality, they don't treat heart failure per se. They don't improve the way patients feel. They don't improve patients' exercise ability. They don't improve other endpoints that are really meaningful to patients. So adding a therapeutic benefit, heart failure therapeutic benefit on top of an ICD makes great sense. And I think that's coming. Now let's take a look. Some additional questions that I have here. What about the effects of CCM on LV remodeling or reverse remodeling? There is evidence both from animal models as well as in human studies that demonstrate reductions in left ventricular volumes, both systolic and diastolic volumes, associated with an improvement in ejection fraction. That improvement in ejection fraction is similar to what we see with the use of CRT in patients with wide QRS complexes. And speaking of CRT, a number of questions were raised about CCM and CRT. First of all, let me remind the audience that CRT is indicated for about 20% of our reduced LV ejection fraction heart failure population. So for patients with ejection fractions of 35% or less, the strongest indications for CRT, those associated with a very wide QRS complex and a left bundle branch block, might capture about 20% of the overall heart failure population. The majority of heart failure patients have either a narrow QRS, where we know that CRT does not work and in fact might be dangerous, or they have a non-left bundle branch block morphology of their wide QRS complex. So CCM may address a much larger population of patients than addressable by CRT. But one of the questions that was asked by the audience was, can you use the two together? And the answer is that theoretically, one could. Currently, there is inadequate data upon which to make a recommendation about the concomitant use of CRT and CCM therapy. But it certainly is an attractive thought, particularly in those patients who are CRT non-responders or perhaps have improved but improved inadequately with CRT alone. So more studies to come. I think we'll have more data on the concomitant use of CCM and CRT therapies coming in the future. Let's see if there's anything I missed here. I think that covers the highlights. One question was, how did this concept originate? I honestly don't know. There have been, there's been some thinking related to what happens to contractility after blocked premature contractions, and whether or not that potentiates contractility for the next beat. But, I really can't give you an answer about how the thought originated. But now, after many years of study, the concept seems to be well proved.
Great. I think we'll come back with some more questions. So let me answer two questions which were dedicated, directed to Dr. David Rich after the wonderful talk. That how will the experience change? Plan for a potential resurgence. What would the system do differently? So Dr. Rich comment is, thanks for the kind words. For a future surge, the logistical plan is largely identical, albeit easier to manage with more adequate reserve of PPE and other supplies, promising trends for therapeutics and respiratory equipment. As a health system, we learn to share best practices such as access to research trial in all our hospitals and seamless transportation among hospitals to optimize patient care. We'll continue to improve those processes. Second one was that did your hospital staff contract COVID or die during the time? So he said, sadly, a small number of Mount Sinai healthcare workers succumbed to COVID-19 among our 42,000 system employees. We mourn their loss and rededicate ourselves to fighting the pandemic. Yet, with alternative medical care for those who become ill and consistent social masking and social distancing practices until vaccines are widely available, we have kept many safe and will continue to do so. Basically is that, yes, it could happen, but we need to be maintain all the precautions. With that note, Dr. Keeney, you got some questions?
Yeah, I have my questions. One of the question was ongoing trials for mitral clip repair in primary severe MR with poor surgical risk or due to other comorbidities. Yes, there are several ongoing trials. There is a clip, I mentioned the clip that was approved. There's another, which I showed also, which was the Pascal clip, which is ongoing. And I think in the anatomy of the mitral valve, I did mention how complex the mitral valve is. So there is no one treatment for the mitral regurgitation. So whether it is primary or secondary, so the various devices need to be considered depending on the pathophysiology of the MR, where the MR is arising from, and then we can make a decision what is the best treatment for the patient, clip or repair. And then comes for a tricuspid clip. Would carcinoid tricuspid disease qualify for a triluminate trial? All depends, whether the type of regurgitation, when we do the echocardiogram, TE will determine, how significant it is. And yes, just because they have carcinoid would not be excluded. But of course, there are other, if carcinoid is involving other body parts will be difficult, maybe based on what the trial enrollment criteria is. Then there is another question saying, how does a carillon mitral annuloplasty compare to mitral clip? No comparison has been done. I know there was a small study showing that it was done for secondary MR patients with heart failure, essentially decreasing the annulus. Yes, it did decrease the mitral regurgitation, but head-to-head comparison has not been done in this patient. And then the other question was, what can be done for severe TR if there is a pacemaker wire? Again, the issue will be the same. Which part of the the valve, the pacemaker wire is? If it is in the center, will be a major issue to clip it. So a couple of cases, what you have done is then you have to remove the the wire first. They can remove the wire and then put a leadless pacemaker if the patient is pacer dependent. If the wire is on the side closer to the commissure, then of course we can place a clip with the wire in place. And the last question was that about a broadcast case that we had done. It was a live case. The person mentioned that we did a tower. It was actually, it's a mixed question. The case we did was mitral case where a prosthetic valve, the case exactly that I showed, where you can place a sapien valve in patients with a degenerated prosthetic mitral valve. And during the live case, we did have some issue that the valve got stuck. Patient did go for surgery. Those are the questions.
So I think there are more questions which we'll ask individual. One question was very relevant, was directed towards me. That is that knowing that genotyping testing is not widely available and no solid data, should we just do a platelet function assay on the equimetrics? And so I think that's what we're doing at present. So in cases where there is a borderline, we know that even in complex PCI, non-acute coronary syndrome, if you need to give, you can give ticagrelor or prasugrel. But if there is a question about bleeding and you still have to give clopidogrel, let's say left main. I had a case actually last week. Left main patient has a prior TIA, has a bleeding. So in that particular case, you want to make sure that your clopidogrel is working, although we know that platelet function assay testing guided therapy did not make any difference. There were 5 randomized trials which have been done in this field. But case by case basis on those high risk patients, we still routinely do on those cases if we are not changing to a more potent P2Y12. So only thing what we are doing more and more is take away the aspirin. Where the bleeding issue is there, take away the aspirin and just continue either any of the monotherapy, which I think looking like a data, all 3 of them seems to be quite well. But clearly patients with a super high risk complexity, and you cannot use the newer P2Y12 or more potent P2Y12 or ticagrelor or prasugrel, that case definitely should try to use clopidogrel. So question is, what can you do then? Well, then you may decide maybe still give the more, ticagrelor, prasugrel, or make a clopidogrel twice a day, which for some of the trials in the past have shown. So with that, Roxana, you have some more questions for you?
No, I think from what I'm seeing, we answered pretty much everything, Dr. Sharma.
Okay, now one question was, knowing that now more and more patients are coming on the ticagrelor alone, and now they need a non-cardiac surgery or even cardiac surgery. The surgeons are very much afraid, and now you're giving patient ticagrelor 1 year, 2 year, based on various trials. So how would you manage those, cases? And third question was, another question for you was, if patient is aspirin allergy, how are you managing those patients as a unitherapy or so?
Well, I think we've done this before in our aspirin allergic patients, which it's not that it's quite a rare thing. And in aspirin allergic patients, we brought them in and we've done desensitization, because aspirin in the peri-procedural arena is quite important. And we like to kind of at least give those patients aspirin. If not, we've used glycoprotein 2B3A inhibition and other things in those patients in the past, but it really is not a very large body of evidence to talk about. Regarding what do you do in the patients who are on ticagrelor monotherapy for a prolonged period of time, the most data we have is from TICA monotherapy is really from 2 trials, Twilight and Tycho. Twilight and Tycho both, in fact, Twilight a little bit longer than Tycho. Tycho only had ticagrelor monotherapy for 9 months. Twilight had it for 12 months. We do not have prolonged use of data on prolonged use beyond a year. of use of ticagrelor monotherapy. And we did not see any issue. We're going to be presenting the data on both the sites of bleeding, the reasons why, on the patients who had to go and have surgery and were on ticagrelor monotherapy versus not, and what those bleeding complications were. But we all know that if it's early after a stent, stopping both dual antiplatelet therapies before surgery could have a negative implication for adverse cardiac outcomes, especially in the first week and up to a month after a stent implantation. At this year's TCT, we're going to get data on the Cobra stent, where there is only 2 weeks of dual antiplatelet therapy on these very, very high-risk patients with a Cobra stent, which is a non-drug-eluting, but it does have a formulation of a coating, an a coating on that stent is a polysine coating, which is supposed to be thromboresistant. Only 2 weeks of dual antiplatelet therapies in patients on an oral anticoagulant. We're going to look at that, and we're going to be presenting that, and I think there's going to be some trials with that particular stent in patients undergoing surgery and what to do around the time of surgery. We still are very unclear about what to do around the time of surgery, and as you know, even for non-cardiac surgery, the data is very, very sparse. And what to do around that with, let's say, even use of cangrelor in the perioperative period. The data that we have on the bridge trial, it was for cardiac surgery, not non-cardiac surgery. So there's a lot more that we're looking to explore and working to design studies in this arena to look at this prospectively. At the moment, what we're doing in patients who are on potent agents and need to have urgent procedures, we stop the potent agent, we keep them on the aspirin, and we let them go on for their surgery. That is what we're doing. When it's spine surgery and very, very difficult intracranial surgery, that's when we stop both antiplatelet regimens and watch those patients very, very closely. And in a very rare case, when it's early after stenting, we would do some bridging with the use of cangrelor.
Great. Now, Greg, there is another good question for you. Oh, sorry. Yeah.
I wanted to respond to that last question as well, because it gets even more, I mean, Roxana's points were excellent, but it gets even more complicated. And I think you really have to consider what the ischemic setting was. Were the stents put in because of a recent STEMI, a non-STEMI, or stable CAD? And we know that the stent thrombosis rate goes up almost exponentially, with STEMI being the highest, then non-STEMI, then stable CAD, with about 75% of all the events still occurring within 30 days. So in stable CAD in particular, we really have no evidence that you need anything more potent than clopidogrel. And in fact, we tried to run a 2,000 patient randomized trial called Trigger PCI, which was going to be prasugrel versus clopidogrel in clopidogrel hypo-responsive patients. And we had no events, essentially no events in patients who were on aspirin and hypo-responsive clopidogrel. Okay, so you saw in the Excel trial where there was a lot of stenting done, including left main, how low the stent thrombosis rate is with contemporary stents. So I think in what's really fascinating from Twilight is the results are indisputable. But what would they have been like with prasugrel instead of ticagrelor, and what would they have been like with clopidogrel instead of ticagrelor? And should there be a difference in the way we look at stable and acute coronary syndromes? So I personally was surprised in Twilight there were so many patients on ticagrelor monotherapy with stable ischemic heart disease. I would almost never recommend it, to be honest.
Well, so really good point, Greg, and those are exactly the questions. And I actually disagree with Dr. Sharma, if I can ever do that, because he's put so much of his confidence into the ISAR React 5 study, and I really have a lot of issues with that trial, given that there were many, many issues. But what Greg brings out are important questions. Can monotherapy be very similarly replicated with prasugrel? Is there any role in stable coronary disease for a more potent agent, if ever, especially with complex PCI, which you have done. And is it better than having the patient on aspirin and clopidogrel? What if you put a patient like that with the stable coronary disease instead of aspirin and clopidogrel on just prasugrel or ticagrelor monotherapy, where you really have no issue of non-responsiveness? And if it's a complex, really multi-vessel stents and et cetera, could you really gain the benefit of a more potent agent and reduction of events and similar bleeding? Those are really important questions, and believe me, Greg, we're designing trials like that. So all of your questions are absolutely perfect for the kind of setting the stage for the kind of trials that we absolutely must do in a large scale with really meaningful answers for these important questions.
Beautiful. So let's come back to, I think, unless there is any other question comes, the last question is actually for Greg. And this is a lot of interest on this vulnerable plaque. So question is, patient has non-obstructive CAD. You did a testing, high plaque burden of more than 70%. Statins already has, everybody has spoken about statin, LDL is 65. Would you put this patient on ticagrelor or colchicine?
So again, really interesting question. I think ticagrelor, probably not. We don't have evidence that, again, the antithrombotic benefits from ticagrelor would overcome the increased bleeding. And you saw, I think, in both the Pegasus trial and in Themis that the bleeding can actually be worse than the ischemia benefit. So I think we have to be very careful in whom we use these agents in absent clinical trial data. The colchicine is a very interesting question. And of course, we have a few positive randomized trials now about colchicine, but they're in very specific settings, very soon after STEMI in particular. So I would consider colchicine in a patient with a high CRP who had a recent acute coronary syndrome, but I would almost consider that independent of what my invasive testing was. So we're now at the point in vulnerable plaque where we can identify these plaques. We know they put the patients at increased risk. We know they occur in the patient with systemic inflammation, but it's kind of like driving, to focal cavity formation. And now the question is, do you prophylactically treat the cavities versus not? And we have to answer that in well-designed randomized trials.
Well, with that note, we come to the, unless anybody has issues, yeah, sure.
I just wanted to, I think your point is very well taken. And I fully agree. But let me just add about the Themis trial and the Pegasus study. Now that and this is a question back to you, Greg, now that you've seen what ticagrelor monotherapy is able to do and the platelet substudy showing no real further evidence of further platelet inhibition in presence of ticagrelor for aspirin, would you, if you were to design Pegasus and Themis PCI, would you do a ticagrelor monotherapy arm as opposed to having a additional aspirin on top of TICA? And maybe those results would have been a lot different, and that it wouldn't be just a null effect.
Very important.
Absolutely.
Very
Without any question. In fact, I don't know that I would have the ticagrelor plus aspirin arm after Twilight. I would probably just have the ticagrelor monotherapy arm.